I'm so delighted to be here and to meet all of you. We are going to spend the next 40 minutes or so discussing management of metastatic hormone receptor positive HER2 negative breast cancer, with a special focus on some of the really exciting new agents which are currently in development, either newly approved or in late-stage clinical trials. And I'm hoping that we'll have time at the end for any questions or discussion, and happy also to chat. So I want to just start with a few cases just to kind of wake up our minds. And I won't ask you to vote necessarily, but just to think about it, and I'll tell you the answers, but just to sort of get us going. So our first case, imagine you have this patient. She is 57 years old. Originally, she had a history of stage 2 hormone receptor positive HER2 negative breast cancer. And then 4 years ago, she was found to have metastatic disease to the bone. She had a biopsy to confirm this. She initiated first-line therapy with an aromatase inhibitor and a CDK4/6 inhibitor, and things were good for 4 years. However, her most recent restaging suggests that she has some progression in both lesions. So now I recognize that your access to ctDNA may be different than mine in the United States, but let's imagine you had ctDNA available and you send it for genomic profiling. So in terms of what we're looking for, I would be looking for an ESR1 mutation that may have developed during the time that she was taking first-line therapy. What would be the prevalence of seeing this in people who've had at least 6 months on AI and CDK4/6 inhibitor? Once you take a look at those answers, think of what you would select in your mind. We're going to talk about this a little bit more. And I'll move on, but I'm going to tell you the answer here is 30 to 40%. We're going to discuss why that is in just a few moments. So actually, you don't see an ESR1 mutation. You have a PIK3CA mutation in her NGS. Now, she's feeling well. She works full-time. She likes to travel. So we have to think about how would we treat this patient who's had 4 years of disease stability. She has minimal progression, asymptomatic. Here are some choices for what you might offer: exemestane and everolimus, fulvestrant and capivasertib, fulvestrant monotherapy, or capecitabine. Think about what you might offer. And I'll tell you, all of these are potential choices for her. For me personally, I would be thinking about fulvestrant and capivasertib because she has a PI3 kinase mutation. We're going to talk about why this is helpful. In general, if we have an actionable mutation for which we have an approved targeted therapy, that tends to be the priority for us, even though, for example, exemestane and everolimus would also be a reasonable option here. I always want to go for the actionable mutation. So let's take a jump forward and think a little bit about how we manage patients with metastatic disease. So for those of you who've been doing this a while, you know that treatment for metastatic breast cancer has become much more complicated and very personalized over the past several years as we've had the introduction of many new novel therapies, including therapies that all tend to sit in the same categories of treatment. So it makes it a little bit more complicated for us to be selecting treatments for patients. But we always want to be thinking about some key features. Of course, we want to weigh the risks and benefits. The benefits in terms of prolonging survival, controlling the cancer, managing any symptoms, and optimizing quality of life. And we want to balance that against side effects or the risks, including side effects or toxicity, the time it takes for a patient to be treated, like chair time, and of course, financial toxicity, which again, it can be variable between your health system and my health system. And then fitting into that are the individual factors, and these can be tumor factors, such as how much disease is there, where is it? And I would add to this tumor biology and resistance mutations, and patient comorbidities, and of course, patient preferences. And all of these are very important when we make decisions. This is an algorithm that my colleague Ana Castro put together that I think is a really nice overview for our current guidance for how we would be managing metastatic hormone receptor positive HER2 negative disease. And we're going to walk through several steps of this, but I will point out that for the majority of patients, we are offering endocrine therapy with a CDK4/6 inhibitor of your choice. There's a small percentage of patients for whom the triplet of fulvestrant, palbociclib, and alpelisib is appropriate. We'll talk about that in a moment. But for most people, this is where they begin. We certainly hope that they will have a long period of disease control, but for the majority, eventually there is progression. And here's where it gets more complicated, because here we have multiple choices for second-line therapy. And increasingly, what we need to be learning here is whether there are any actionable mutations through genomic profiling to see if we can use that to assign therapies. And in particular, I want to focus on testing for ESR1, testing for PI3 kinase pathway mutations. And this is where there's some of the newest drug approvals in breast cancer and also some of the most exciting research. And I'll just say as an aside, for patients who have wild type disease, so no actionable mutation, we have nice choices there, including everolimus combinations and continuation of CDK4/6 inhibitor, CDK after CDK. We're not going to get into that too much in this talk, but just for context. So let's start by jumping in with ESR1. Okay, so yeah, how do we pick best therapies after CDK4/6? So ESR1 mutations are what we think of as clonal mutations. They are very infrequently found when cancers are initially diagnosed as primary disease. They are also very rare when patients are diagnosed with metastatic disease at the beginning. However, with continued exposure to aromatase inhibitor therapy, these mutations develop because these are resistance mutations. So we find at baseline, these are samples from some of the major historic trials, the rate of ESR1 mutation is low, only 4%. But after progression on endocrine therapy, so 6 months or more, we're seeing numbers in the 30 to 40%. So that's where we can get those numbers from. 30 to 40% of patients after 6 months will have ESR1 mutations. This means that if you tested, let's say, the primary tumor, you're not going to find it. You test a patient at time of diagnosis of metastatic disease, you are probably not going to find it. It's something that would need serial testing or subsequent testing to identify. Now, we have different ways that we can test for actionable mutations. We could test tumor tissue, or we can test ctDNA through what we sometimes call liquid biopsy. And there's pluses and minuses to both of them, but I will point out, particularly for ESR1 mutations, a ctDNA liquid biopsy would be preferable. We do know that if you look at testing for ESR1 through tissue versus ctDNA, that there is discordance. It's the purple in this figure here, in that the tissue is negative, but the ctDNA is positive. And that's much more so compared to other mutations such as AKT, HER2, or PIK3CA, which is a truncal mutation present in primary disease, present in metastatic disease, so quite different. Additionally, when we do ctDNA, taking a blood sample that goes everywhere in the body. So it gives us the opportunity to sample the entire body, and that's important in cases of heterogeneity. Sometimes cancers are not homogeneous at every single location, so you really can get more of a global view. So in general, liquid biopsy testing tends to be preferred when we're looking for ESR1 mutations. Now, why is this important? Well, we know that if an ESR1 mutation has developed, that the efficacy of an aromatase inhibitor becomes quite limited, and we want to think about a different strategy. The preferred strategy is to use a SERD, selective estrogen receptor degrader. These are medicines that have a twofold mechanism of action. One part is that they will bind to the estrogen receptor, which prevents transcription of estrogen responsive genes. But also by binding to the estrogen receptor, this flags it for degradation. So it has a twofold effect. And we do have a SERD available, that's fulvestrant, but that's an IM injection. It's poorly bioavailable, and there's difficulties getting up to appropriate therapeutic levels. So there's great interest in the new category of SERDs, the novel oral SERDs, which have some specific advantages. They're oral, they're higher potency, better bioavailability. They've demonstrated activity in ESR1 mutant metastatic disease, as we're going to see. And I'll add in this little figure here, there's other variations of estrogen receptor targeting drugs that are under study, including Protac and Sirion. This is a table of the prominent oral SERDs that have been in development. There are 4 agents which are approved or are hoping to get approved. Elacestrant is the agent which is currently approved as monotherapy for metastatic ESR1 positive breast cancer. The other agents that are in phase 3 trials include giredestrant, camizestrant, and imlunestrant. And you can see the names of some of the trials over here. And I point out in red, these are the adjuvant trials. All of these agents have entered the adjuvant space with the hope that perhaps they could replace or be superior to aromatase inhibitors in that setting. And you may have some of these trials over here. And then the 2 other agents I mentioned, the Protac vepdegestrant and the Sirion palazestrant. So let's run through some of the data for these. We're going to start with elacestrant, who's again the only approved agent right now. And as we go through this, we're going to start with monotherapy studies. So these are experiences as monotherapy, typically compared to standard of care endocrine monotherapy, beginning in the pretreated space. So the EMERALD study was a study that enrolled a fairly heavily pretreated population. It's metastatic disease who had had 1 to 2 prior lines of endocrine therapy. 100% had prior CDK4/6 inhibitor, and they could have had up to a line of chemotherapy. They were randomized to elacestrant monotherapy or investigator choice endocrine monotherapy. And you can see the choices listed here. Primary endpoints of the study included progression-free survival in everybody and in a pre-specified ESR1 mutant subgroup. I think it's interesting to look at the patient characteristics in this trial, just because you can see that this is a little bit more pre-treated population. We can see about 70% with visceral metastases, 100% prior CDK4/6, about 40% it had 2 prior lines of endocrine therapy, almost 30% with a prior line of chemo. This is going to be different than some of the studies we're going to see following. Here are the primary results from this study. So the use of elacestrant was superior to standard of care in both all patients as well as those with ESR1 mutation. And when you are focused over here, you can see the improvement in progression-free survival, 1.8 months to 3.8 months. We might look at this and say, that's a little bit modest. And I think that's accurate, although some of that is because of the way this curve looks. And it's actually quite interesting to look at the shape of this Kaplan-Meier curve. You notice that when this starts, there's this very steep drop-off at 2 months. That's when patients get their first set of scans. So about half the patients have progressed at time of first restaging. That really speaks to that the population enrolled in this study was probably a lot of endocrine-resistant patients. Once those patients progressed and left the study, you are left with the endocrine-sensitive patients. Here now you can see the difference between the curves, and that elacestrant is superior to the standard of care endocrine therapy, particularly in these cancers with ESR1 mutations. Now, could we refine that even more to identify the best candidate patients? And this is a subgroup analysis that is looking at time on prior CDK4/6 inhibitor therapy and then outcome. And it has nothing to do with CDK4/6 specifically. It's more about endocrine sensitivity. We can see that patients who had disease control for at least a year on their prior line of therapy, they have a pretty dramatic benefit from the use of elacestrant in these patients with ESR1 mutation. We can see an improvement from 1.9 to 8.6 months, hazard ratio 0.4. So if I'm thinking about in my clinic, who would I want to offer elacestrant monotherapy to? It would be a patient who has these markers of being endocrine sensitive, where hopefully that is retained and I'll be able to get benefit from the use of elacestrant. Let's turn to another monotherapy study. This is SERENA-2. This is looking at the oral SERD camizestrant. And this is also a randomized study. It actually is a bit of a dose-finding study. Patients here had up to 1 prior line of endocrine therapy, up to 1 prior line of chemotherapy, and they were not required to have all had CDK4/6 inhibitor. They were randomized to what is essentially 2 dose levels of camizestrant, 75 and 150. The 300 kind of went away during the course of the trial, or fulvestrant monotherapy, with the primary endpoint of progression-free survival. And again, I'll point out the ESR1 mutation population is about 30 to 40%, and about 20% of patients had prior chemotherapy. You can see about half had prior CDK4/6 inhibitor, so maybe not as heavily pretreated as the EMERALD study. Similar results, though. Here we see that the benefit from the oral SERD from camizestrant was most notable in patients with an ESR1 mutation in their cancer. We can see here an improvement from 2.2 months to somewhere between 6 to 9 months, depending on the dose level. And that's absolutely not seen in patients with wild type ESR1. So here's this building signal that the benefit of the drug is in ESR1 mutant cancers. Now let's turn to a third study, EMBER-3, looking at the oral SERD imlunestrant. Now this study has monotherapy, but this study is also going to introduce for us combination therapy. So again, these are patients with pretreated disease. These patients they'd all had CDK4/6 inhibitor plus minus aromatase inhibitor, but no other therapy. So no chemotherapy was used in this study. So again, we're getting even less heavily pretreated patients. And patients were randomized to monotherapy, imlunestrant alone, or provider choice standard of care endocrine. Then there was a third arm added a little bit later. That's what this indent means. That was imlunestrant with abemaciclib. So here's a combination of 2 drugs. There are 3 primary endpoints for the study: imlunestrant monotherapy versus endocrine monotherapy for ESR1 mutant. Same thing for all comers, so just like we've seen in the other studies. And then for the combination arm, imlunestrant monotherapy versus the combination. So let's see what happened here. Here's the baseline characteristics, similar to the other studies, about 30 to 40% ESR1 mutant, about 40% PI3 kinase pathway. That's very expected. And we can see about 60% of patients had prior CDK4/6 inhibitor. The ones who didn't were patients who were coming into the trial as first line who had not had it in the adjuvant setting. But there's only like a handful of people who had adjuvant CDK4/6 here. And here's the results. So again, very similar to the other studies. In patients with an ESR1 mutation in their cancer, there is a benefit from the oral SERD monotherapy. And here with the use of imlunestrant, it improved 3.8 to 5.5 months. This was not seen in the wild type patients, 5.5 versus 5.6. Now there's a third study showing us monotherapy is helpful if there's ESR1 mutation. But the very interesting thing in EMBER-3 is the combination. So the combination, which is the red, this improved progression-free survival to 9.4 months, which is better than the 5.5 with imlunestrant monotherapy. And what was interesting is this was seen in both the ESR1 mutant and the ESR1 wild type. So unlike monotherapy, which is restricted to ESR1 mutation, when you give a combination, perhaps it seems to overcome any restriction based by the ESR1 mutation. And my colleague Hal Burstein put together this figure in his ASCO discussion, San Antonio discussion, looking at the median progression-free survival in all of the post-CDK studies. And of course, big caveat, you are not supposed to do this. You're not supposed to compare all these trials side by side, but it is pretty interesting to look at. And you can see that this combination arm at 9 months is vastly superior to all of the other experiences here, the majority of which are all just monotherapy. So I think this begins to build an argument that for oral SERDs, or perhaps we can just say endocrine therapy in general for metastatic disease, we are best served by giving combinations. This is where we're going to see our greatest responses, as opposed to giving monotherapy in all of these other trials. So this is looking at it's the forest plot from the EMBER-3 study looking at subgroups. It is quite interesting to look at previous CDK4/6 inhibitor because the stronger signal for benefit was in patients who already had CDK4/6 inhibitor. It goes a little bit against, I think, our thinking, where we would imagine a CDK4/6 naive patient would have the most benefit, but the small group who were listed here actually didn't have quite as much as those who had prior CDK4/6. I don't quite understand, but it's been now shown a few times. We also see, though, that if patients had ESR1 mutated cancer or not, PIK3CA mutated cancer or not, everybody got benefit. It didn't matter if there was an actionable mutation when you were giving the doublet. We also saw some data at ESMO Breast this year looking at the small but unique population of patients with what we might call co-mutations. So someone whose cancer has both ESR1 and PI3 kinase. And we can see that in patients, in all these patients, they were all ESR1 mutant, or those who had CDK4/6 inhibitor before, substantial benefit from the combination over imlunestrant monotherapy. Here we're reaching a progression-free survival of almost 13 months, which is really quite striking. And suggests that if you have both mutations, it's appropriate to consider offering a SERD or offering a PI3 kinase agent, depending on the patient's situation and side effect profile. I think ultimately what we'd like to have in these situations is the combination of a SERD and a PI3 kinase targeting agent together instead of just a CDK4/6 inhibitor. Now, there are many other ongoing trials looking at oral SERDs, and I'll just point out these two phase 3 trials, which are ongoing. Avera is with giredestrant, randomizing to giredestrant and everolimus versus endocrine therapy provider choice and everolimus. And the Adela study, which is essentially a repeat of the old Bolero 2 study, elacestrant monotherapy versus elacestrant and everolimus. So we await results for both of these two studies. Now let's shift ourselves from the pre-treated setting to thinking more about the first line setting. And I want to kind of set the stage for the idea of how we monitor patients for the development of ESR1 mutations. There was a trial presented several years ago called POTA-1, which was a really interesting, I'll say, experiment thinking about how we can be monitoring patients the moment that ESR1 mutation develops, what we might call molecular progression. So can we detect that? And if we detect it, should we do something about it? Is that helpful? So in this study, patients who are receiving first-line therapy with AI and palbociclib, a CDK4/6 inhibitor, had serial blood samples to look for ESR1. And so they had them essentially every 2 months. If an ESR1 mutation was detected, but the cancer had not progressed, they moved on to step 2, where they were randomized to either stay on AI and palbociclib or switch to fulvestrant and palbociclib. So fulvestrant being a SERD, better for an ESR1 mutation. So first thing we learned from this study is, like we talked about, ESR1 mutations are kinetic. They increase with time. And in the first 6 months, the rate of ESR1 mutation was 18.7%. After the first 6 months, it's up to 53%. So just like we've been talking about, it increases with time. How about the results? So this is the progression-free survival result from PADA-1. It shows that the patients who switched to fulvestrant, which is the light blue, had a significant prolongation in progression-free survival compared to those who stayed on aromatase inhibitor, about 6 months to about 12 months, so a doubling in progression-free survival. They've also looked at progression-free survival 2, PFS2, and the benefit obtained in PFS1 is maintained in PFS2, 29 months versus 14 months. So very provocative, and this sets the framework for a study that we saw at ASCO this year, the SERENA-6 study. This is one of the plenary presentations at ASCO, and this is essentially building on the PADA-1 framework, but instead of using fulvestrant, using camizestrant, one of the novel oral SERDs. So let's look at the structure of the study. So this is the step 1 of SERENA-6. 3,325 patients were entered into screening and had serial ctDNA for the development of ESR1 mutation, essentially at the time of restaging. If the test was negative, so no ESR1 mutation, they just continued. But if an ESR1 mutation was identified, and that happened in 548 patients, then there was the possibility to move on to step 2 of the study. Now, of these 548 patients who had ESR1 mutation identified, half of them, it was positive. I should add, these patients had all been on CDK4/6 for at least 6 months. In half of them, this test was positive at the first draw. In about 40%, it was positive after 2 to 5 tests. And in 11%, it was positive after 5 tests. So essentially 90% of these ESR1 mutations were picked up by testing at least 5 times. Of the 548, 315 were eligible to be randomized. And the primary reason for eligibility was finding the mutation, but not having clinical progression. People who screen failed at this point mostly had clinical progression. So they move on to step 2. And this is a more classic randomized structure. These patients were randomized to switch their endocrine therapy to camizestrant, continue their CDK4/6 inhibitor, and take a placebo for AI, or stay on AI, stay on CDK4/6, and take a placebo for camizestrant. So it's a fully blinded study. Patients switched endocrine, but nobody, neither patient nor provider, knew what they were receiving. Primary endpoint of the study is progression-free survival, with PFS2 and overall survival being key secondary endpoints. So let's take a look at what was presented. So here's the primary endpoint of progression-free survival. The patients who made the switch to camizestrant had a prolongation from 9 months to 16 months with a hazard ratio 0.44. So this was a successful strategy to make the early switch at time of molecular progression ahead of clinical progression. This is the forest plot from the study, and we can see that in general for all of the subgroups, it was favorable to make the early switch to camizestrant. And I'll point out that this included people who were picked up on who were diagnosed with the ESR1 mutation earlier versus later, for people who had it at the first test versus a subsequent test. All of the groups appeared to benefit. We can also see all of the ESR1 mutation versions were also benefiting. I think one of the most important figures from the SERENA-6 presentation is actually the quality of life. And it's interesting because many of our major trials in breast cancer often are presenting quality of life data. It's kind of unusual that we learn something from it that we didn't already know or assume. But here in SERENA-6, this is looking at time to deterioration in global health status. And we can see that the patients who made the early switch to camizestrant had a dramatically prolonged time until deterioration in global health status, from 6.4 months to what's actually 21 months. So it's about a 1.5 year prolongation of feeling well. And you can see that the curves separate pretty quickly in the beginning and remain separated. So something's going on the patient level that's really helping patients continue to feel well and continue to maintain their health status compared to those who stayed on the aromatase inhibitor despite the ESR1 mutation. Now, PFS2, I mentioned, is a key secondary endpoint, but is immature. At the time of first report, this is trending favorably with a hazard ratio 0.52, but we still need more time and events to be able to report on PFS2. So when this data was presented at ASCO, this is exciting yet controversial because we don't really have any studies that have this design and have this framework, and it's hard to understand in some ways some of this data. For example, looking at PFS2, is this really PFS2 versus PFS2? Because one arm has actually changed therapy 3 times and one arm has changed therapy 2 times. So are you really comparing PFS2 to PFS3? It's hard to know. Additionally, when patients progressed, they didn't all jump over and get camizestrant. They went on to get other therapies. Camizestrant is not an approved agent. Elacestrant, which is approved, is not globally approved. So there isn't really a way to ask the question, is it better to switch early or switch late? Many of our trials have this challenge because when we designed clinical trials and we're looking at overall survival, trials are not automatically built to offer crossover. So that is a limitation of the trial. But I think, with more time, hopefully we'll have a better sense of how durable these responses are and whether this translates into ultimately an overall survival benefit, which of course would be the goal for the patients. And just one more point about POTO1, as we are sort of thinking about, could we operationalize this in clinic? Does this mean I have to be checking ctDNA every 2 months for like all of my patients? It is interesting to look at POTO1 at this curve down here, which is the instantaneous incidence of ESR1 mutation, starting at time 0 in POTO1. And this rises pretty dramatically up to 6 months. And then between 6 and 30 months, there's a plateau where one is most likely to identify the ESR1 mutation. And after 30 months, it drops. So it suggests to me that if one were to operationalize this, the time to check would be between 6 months and 30 months. And we know that if you've checked 5 times and you don't find it, it's very unlikely you're going to find it after that. So in my mind, that's what I'm carrying through. If I were to do this in clinic, that's who I would be focusing on. Now, we also have first-line trials for oral SERDs. There's the Persevera trial with giredestrant in the first-line setting. We have Serena-4 with camizestrant in the first-line setting. So we'll await results of this and see if this will, in some ways, displace the Serena-6 mechanism if these trials result in positive. Now, what's the safety profile like for these drugs? Well, oral SERDs are endocrine therapy. They are very well tolerated. And if you look across the board in the monotherapy experiences, which really isolate how the drug is tolerated, there's like a little GI side effect, there's a little fatigue, but overall, these are very well tolerated drugs. Camizestrant does have 2 unique side effects that are mentioned. There can be asymptomatic bradycardia. You can see from Serena-6, it's dose dependent, and it's relatively uncommon at the 75 milligram dosing. There's also something called photopsia, which is when patients may notice some flashing lights, or what sometimes people call after images during low light conditions. Like if you were to move your head, you might just see a little something. It doesn't affect visual acuity. It doesn't affect the eye structure. It doesn't affect activities of daily living, but it is something that a patient might notice. And in terms of grade 3 side effects, there's practically none. So again, very well tolerated drugs and drugs that can be combined with other novel therapies. This is just looking at the toxicity profile from Serena-6, and you can see most of this is driven by the CDK4/6 inhibitor, where you have substantial rates of neutropenia, which are not unexpected when we use drugs like palbociclib or ribociclib. Now, there are some other emerging agents that we've referred to that are also coming through in phase 3 trials. We recently saw data from the VERITAC trial of the PROTAC vepdegestrant. This is another monotherapy experience post-CDK4/6 inhibitor. Patients randomized to vepdegestrant monotherapy or fulvestrant monotherapy. And we saw results that in many ways resemble what we saw for the oral SERD monotherapy. A nice benefit in ESR1 mutant cancers, 2 months to 5 months in progression-free survival, but no benefit in the ITT population in all patients. I think vepdegestrant has a very unique mechanism of action, and I think there was some hope that this would have a little more activity in the wild type, but certainly it has it in the ESR1 mutant. There's lasofoxifene, which is an oral SERM. This is a drug that's also performed well in early studies in ESR1 mutant populations. It's currently being looked at in a phase 3 trial called ELAINE-3. That's for ESR1 mutant cancers. And then we also have palazestrant, which is an oral Ceran. This drug in monotherapy had a lot of activity in quite heavily pretreated patients. These are patients three or more prior lines of therapy, prior CDK4/6, prior chemo. So pretty pretreated population. And you can see in this waterfall plot, there's a lot of activity there. And so palazestrant is now in one and maybe two phase 3 trials. There's OPERA-1, which is looking at palazestrant monotherapy post-CDK. And then OPERA-2 will be a first-line study with CDK4/6 inhibitor. Okay, so we're completed on oral SERDs. We're now going to change gears and talk a little bit about agents that target the PI3 kinase AKT mTORC/PTEN pathway. Moving forward, I'm going to refer to this as PI3 kinase pathway or just pathway. Otherwise, it's quite a mouthful. As we mentioned before, about 40% of hormone receptor positive breast cancer will harbor a mutation in one of the steps of the pathway, and that offers many opportunities for targeted therapies. One of the first agents that was approved for cancers with PI3 kinase mutations is alpelisib, which is an oral PI3 kinase inhibitor studied in the SOLAR-1 trial. This was a trial done several years ago, so it was kind of predated CDK4/6 inhibitors, but it was for patients who had progressed on prior aromatase inhibitor, and patients were randomized to alpelisib and fulvestrant or placebo and fulvestrant, studied in PIK3CA wild type and PIK3CA mutant. Primary endpoint was progression-free survival, and this was quite positive in the PI3 kinase mutant population, an improvement from about 6 months to 11 months. And this was the basis of the FDA approval for alpelisib. Only about 6% of patients in SOLAR-1 had prior CDK4/6 inhibitor. So a follow-on study was done called BYLieve that looked at activity of the SOLAR-1 regimen after CDK4/6 and showed fairly similar results. So we do feel comfortable offering this in a post-CDK4/6 setting. Now, if you've given alpelisib clinically before, then you are familiar with the side effect profile, and there are some notable side effects, and hyperglycemia is one of them. About 64% of all patients had hyperglycemia, and about half of that is grade 3. And grade 3 hyperglycemia is very difficult for us as medical oncologists to manage. We're not endocrinologists, and we're not as facile with using antihyperglycemics. At least we're getting there. But this has been a difficult toxicity. Additionally, one can see diarrhea and rash. So it's a pretty rigorous agent to be using. So it was very nice when we had a new agent approved, capivasertib, an oral AKT inhibitor. This was approved based on the Capitello 291 trial. This was also a trial for pretreated disease, up to 2 prior lines of endocrine, up to 1 prior line of chemotherapy. And I will point out it required a hemoglobin A1C less than 8. In SOLAR-1, that limit was less than 6.4. So a little bit more lenient here with the hemoglobin A1C. Patients are randomized to capi and fulvestrant or placebo and fulvestrant. I'll remind you that capi is dosed intermittently. So it's dosed 4 days on, 3 days off. So like a patient could take it Monday to Thursday, and then Friday, Saturday, Sunday off. And that was designed to help reduce the emergence of toxicity. Primary endpoints of the study included progression-free survival in all patients and in patients who had an AKT pathway alteration. And the study met the dual endpoints. The use of capivasertib was helpful in both ITT and AKT altered, although in the AKT altered, it was a more profound benefit, the hazard ratio 0.5. And this led to the approval of capivasertib in patients whose cancers have a mutation in the AKT pathway. So that can include a PI3 kinase mutation. In terms of adverse events, the prominent side effect of capivasertib is diarrhea, 72.4%, although not that many people with grade 3 diarrhea. Nausea and rash were also observed. I will point out that hyperglycemia was much less here, only 16%. Another one to look out for is stomatitis, 14%. So these side effects are better than what we see with some of the other agents. I will say with the diarrhea, I sometimes find with my patients that on day 4 is when the diarrhea begins. So I have them take an Imodium on day 4, maybe day 5. That helps prevent it from becoming a significant thing. And now let's move on to the final one that has been approved, inavolisib. And this is a more traditional PI3 kinase inhibitor studied in the INAVO120 trial. This trial is important because instead of enrolling that post-CDK type of population, this is actually a first-line trial for high-risk patients. These are patients who recurred on or within a year of their adjuvant endocrine therapy. These are not patients who recurred 8 years later. These are not de novo metastatic patients. These are high risk. And I also will point out the hemoglobin A1C threshold here was less than 6, so very tight. Patients are randomized to the triplet of Inavo, palbociclib, fulvestrant, or placebo, palbociclib, fulvestrant. So essentially a triplet versus a doublet. I will point out that palbociclib is selected very intentionally here. Of the CDK4/6 inhibitors, palbociclib is the best tolerated. It is the one that combines the best in triplets. One cannot swap out palbociclib and add ribo just because you like ribo. You can't do that because it'd be too toxic. So the regimen is specifically meant to include palbociclib. Primary endpoint was progression-free survival. And here's the primary endpoint. At the time of first report, we can see there was a substantial improvement, 7 months to 15 months with a hazard ratio 0.43. It's definitely striking given the dramatic improvement, but I think it's also striking how poorly the control arm does. 7.3 months is really very short, especially when we think about some of our first line CDK4/6 inhibitor trials, which had a much longer time until progression with the doublet. And so I think that really just speaks to this being a very high risk population. And I'll also add that the study was run globally, and about half the patients came on the study with tamoxifen as their endocrine therapy, their adjuvant endocrine therapy. That would be different than my practice, where most of my patients get aromatase inhibitor or aromatase inhibitor with ovarian suppression if they're high risk. Not many people taking tamoxifen, so that may also color a little bit who was in the trial. We saw updated data at ASCO this year from this study, and the progression-free survival is now even longer. Now it's prolonged to 17 months. So we see this is maintained. And we also saw, interestingly, there's an overall survival benefit, an absolute improvement of 7 months with the use of the triplet, which I think, on the one hand is very compelling because it's very unusual for us to see overall survival benefits for metastatic hormone receptor positive disease, usually because people get so many lines of therapy afterwards. But I think that speaks to the high risk nature of this population, and they may not have actually had too many lines of therapy afterwards. We did get some information about subsequent lines, and we get some hints of this. For example, in the placebo arm, 72% of patients received chemotherapy as the next step. I'm not usually giving people chemotherapy second line. And granted, again, this is a global trial, different practice patterns, but I think this speaks to these patients being high risk, and when they progress, they must have progressed in a very aggressive way. We do see lower chemo use in the Inavo arm. But also, PI3 kinase inhibitors in the countries where this was done may not have been globally available. We see very low use subsequently, including very low use second line and placebo. So we're not really looking at a give PI3 kinase first versus second here, because they just didn't get it second. And we just don't know if it was because they couldn't access it or if they were just so sick that they had to move on to chemotherapy as the next step. I do think that I think it's a little sobering, and it does make me think that if these cancers are indeed so aggressive, then we do need to try to offer the PI3 kinase early on and see if we can avoid these patients going to chemo and then maybe dying of their disease. We have to do more for them upfront. Inavolisib is a challenging drug, and some of the side effects that we're seeing included 50% with all-grade stomatitis, about 60% with hyperglycemia, diarrhea, nausea, rash. There's a fair amount of toxicity here. And we've been working at Dana-Farber to establish some internal guidance for how to start patients on inavolisib. For example, taking a daily non-sedating antihistamine to prevent rash, using steroid mouthwash to prevent stomatitis. I give patients a glucometer and have them check their blood sugar at least every 3 days, if not daily, and try to use metformin very early on if there's any rise in blood sugar. But it's still, it's a lot to juggle, and it's complicated for patients. And then the newest news we've heard is from this agent gedatolisib. Gedatolisib is actually a pan inhibitor. It inhibits mTOR and it inhibits PI3 kinase. The other interesting thing about it is that it's intravenous. So this is not a pill, but it's actually a weekly IV infusion. We heard about results from the PI3 kinase wild type arm of a study called Victoria-1, where patients were randomized to a triplet, geda, palbo, fulvestrant, a doublet of geda, fulvestrant, or fulvestrant monotherapy. And we heard that both the triplet and the doublet were superior to fulvestrant monotherapy. Not very surprising, since We know that fulvestrant monotherapy is not a very active regimen, but we look forward to seeing this data presented at a meeting. We also heard that discontinuation rates were low, and gedatolisib does have a reputation as being well tolerated. So I think we'll have to be deciding, good tolerance and activity, but weekly IV treatment. And when we're giving oral therapies to our patients with ER-positive disease, part of the issue is we want to keep them out of the chemo chair. We're trying to delay that. So is that actually helping us if they're coming in every week and getting IV treatment? So just a summary again of the toxicities of the three available agents: alpelisib, inavolisib, capivasertib. Blue is better. So we see that capivasertib is winning for hyperglycemia and mucositis. Inavo is winning for diarrhea and rash. Alpelisib doesn't win for anything, despite the tight A1C. And I think anyone here who's used alpelisib will agree with me on that. It's a difficult drug. Now, these hemoglobin A1Cs are relatively tight. Where I live in the United States, in the Northeast, most of my patients are fine with this and they'll fit into this categories. The Southern United States, many patients have an elevated hemoglobin A1C and it's trickier to get these drugs into them. And then gedatolisib, we'll wait to see what the data looks like and how this fits in. So how can we improve the power of PI3 kinase inhibition, but improve tolerability as well? So the next wave is going to be the mutant-specific PI3 kinase inhibitors. So that the problem is that when we are treating with a non-mutant specific, a pan PI3 kinase inhibitor, it's targeting the mutant PI3 kinase in the tumor, but also the wild type PI3 kinase in our normal tissue, in our liver, in our muscle, and that's where a lot of the side effects come from. So the newest wave of agents is meant to target just the mutated PI3 kinase in the tumor and not touch the normal tissue. So two lead agents in this space include a drug from a company called Relay and a drug from a company called Scorpion. Now it's bought by Lilly, so it has a different name. These are both in phase 3 trials now, and so we're going to hopefully see data from these relatively soon. And I think these would be a welcome addition if they do indeed give us the efficacy without the side effects. Other targeted agents just to be aware of, there are next generation CDK inhibitors, including a drug called atirmociclib, which is a CDK4 inhibitor. This is currently in a phase 3 trial called the 4-LIGHT trial. And it's put up against all the other CDK4/6 inhibitors. So we'll see if this one wins. There's also CDK2/4/6 inhibitors. There's a very interesting class of agents called KAT6 inhibitors. They prevent histone deacetylation. They decrease transcription of the estrogen receptor. They may be of best use in the post-CDK space of endocrine resistance. And then, as we talked about, mutant-specific PI3 kinase inhibitors. So back to our treatment algorithm. It's complicated, but we have a lot of great agents, and I think learning how they fit and learning how to use our biomarker information to assign them is very important. And I put in here the Serena-6 regimen. If this became a thing, we could see this as sort of a 1.5 line of therapy. So in conclusion, hopefully from the data I've shown you, you'll agree with me that the era of endocrine monotherapy is over, and that in general, we should be thinking about doing partnerships between endocrine therapy and novel therapies. We have many options available after progression on CDK4/6 inhibitor, including oral SERDs, PI3 kinase pathway inhibitors. And we want to try to use genomic testing to, at the beginning and moving forward, to help assign these therapies. There's some really exciting agents in development, and I think the breast cancer space has been super exciting over the past few years. And with all these new trials going on, it's going to continue to be super exciting. And, it's also setting up a lot of questions about resistance and how we identify resistance. And in particular, is early intervention better, like we saw in Serena-6? So great space to be in. And I hope you all agree with me. That's it. Thank you.
Thank you so much. Thank you so much for that excellent overview. Very comprehensive and thorough, and it's nice to see what future directions are going as well. Maybe we'll start if there are any questions here, or if you are online, and raise your hand or put your question in the chat.
Dr. Mayer, Carlos. So, are you using, at the beginning you were mentioning that you're using ctDNA with some patients to identify these type of mutations. How is in your regular practice, how you actually are using these on the everyday, because as you've mentioned, with the design of the Serena 6, it looks like a good idea. The data is strong, and I think it's really interesting. The problem is how we can actually follow all those ctDNAs, particularly here in Canada. Then we will need to get approval first to actually get that done. So that is going to be a limitation, not from the breast cancer perspective, but also it's because I treat GI cancers. And actually, we do have ctDNA approval for that, and it's a nightmare. So it's to actually get the ctDNA rolling every time we need it in the adjuvant setting. So I'm not sure how you do that, like yeah, we know it's a different setting, but what is your setup like?
Yeah. So, so first of all, when we send ctDNA at my institution at Dana-Farber, it's a commercial test. So we send it out to a company, Natera, Guardant Foundation, Harris. There's like all these companies that do it, and our contract changes over time. It is covered by a patient's health insurance, so it is paid for. Typically, we will send it at the time of diagnosis of metastatic breast cancer. Now, I'm also trying to biopsy the patient, and I will send the tissue for NGS testing, but that takes time. And so knowing now about the Inavo data and knowing I need to know PI3 kinase status as soon as possible, on the day I see them and say, I'm worried you have metastatic disease, I'm going to arrange biopsy. I also want to do this blood test, and we're going to wait for that too. It comes back about 2 weeks later, and that's usually about the time I'll have the path back from the biopsy to say, yes, you have metastatic disease. So the timing works out well for me to use that data. Moving forward, our ASCO guidelines and ESMO guidelines, it's recommended to check ctDNA at times of disease progression, because if there's an ESR1 mutation, then we have the option for elacestrant or perhaps other choices in the future. And I might send the ctDNA a week or two before the scans if I'm beginning to feel a little worried about someone, so I'll have the data back in time. So that is our current standard of care. Now, you are absolutely right. Serena 6 would be a big burden for us because it's much more testing than any of us have been doing. And at this point, no one in our group has been moving towards doing the serial testing. Additionally, because if you found a mutation, we don't have approval for the next step. You know, you can't give them elacestrant instead. That was not part of the trial. So we're not going to do anything unless there's an approval. But I think what I would like to have happen, and I suspect this is possible, is ctDNA testing has evolved so dramatically over the years. And what used to be a somewhat research-only exotic thing to do is now very routine. And I suspect that our own internal pathology offices will develop the technology where they will run it like they do a tumor marker and say, check this for ESR1. I don't need the whole profile. I don't need to know, the P53 or FGFR. I just want the ESR1. And so we could just ask them, just check it. And I suspect that's the way we're going to end up doing it. But I don't have that available yet. I've asked enough people, can you figure it out? And we'll see.
I think you're a little closer to us though, because we only have a one-time testing and it's just tissue-based. I think some of our patients, they can afford to pay out of pocket, they could choose to pay for it. Great. Yeah, last one while everyone's thinking. So in the case we showed the data when patients have concurrent and running treatments. CDK inhibitor. What are you likely to move to, given that we do see that strengths and demonstrate the all comfort? Would you go more, targeting the PI3 kinase pathway or more lead?
Yeah, I think it's a really important question, and we have that data from EMBER-3, and there's also data from the Emerald study that shows us that if you have co-mutations, you are still getting benefit from the oral SERT. Currently, if I was going to target the ESR1, the only way I can do that right now is with elacestrant monotherapy. And elacestrant monotherapy is a great choice for, let's say, an older patient with kind of indolent disease who has low volume disease. Things are just happening slowly, long period of disease control on prior CDK4/6. That's where I've had my best success with elacestrant. If somebody has more rapidly progressive disease or higher burden of disease, I don't think that elacestrant by itself is enough. And so I'm often using those clinical features to help decide what to do. I think when we think about PI3 kinase mutations, this is one of the fundamental resistance mutations. And we see from Inavo that the biology and the behavior of these is much more aggressive. So in general, I'm leaning towards picking the agent targeting the PI3 kinase pathway, with the exception being that if my patient is that older indolent patient, then elacestrant monotherapy would be my choice. I think in the future, when we have combinations, then we'll be able to sort of do both at the same time.
Right. Yeah, for us here, we have we don't have an oral SERT available, so I mean we have fulvestrant, and we will have like option 2 second line CDK with abemaciclib. Any other questions? No. I'll ask one more question. I'm curious what you do, Dr. Mayer, in the case of, let's say, the endocrine resistant patient population where you're applying the INAVO data. As you showed, the control arm doesn't really do very well, and the pattern of disease progression can be quite, aggressive. What would you give upon progression? After the INAVO combination, would you try another endocrine-based strategy with a different CDK, or would you jump more to chemo, or if they're HER2 low, TXT?
Yeah, so I haven't had enough experience with it to say clinically, and I don't know enough about the post-progression therapies of the trial to be able to learn from that. I do think, though, here's where we as medical oncologists are going to use our knowledge of kind of what happens to make those decisions. Because if somebody has a long period of disease control and things seem relatively quiet, second-line endocrine therapy makes a lot of sense. And if they already had PI3 kinase targeted, I'm not going to give capivasertib because we don't know that giving one after another is helpful. Maybe I'd give an everolimus-based regimen. Maybe I'd do a post-monarch type regimen with abemaciclib in that setting. But if somebody has like one hot minute of disease control and then things keep growing, I'm reaching for TDXD in that setting because that patient does not have endocrine sensitive disease and they need a response. I will add, and it's not, for those coming tonight, you'll see slides tonight on this, but I'll mention it right now. Another similar question that's come up is for patients who receive adjuvant CDK4/6 inhibitors and then have recurrence, what do we do? Thankfully, we don't see this too much because adjuvant CDK4/6 is very effective. But for the small number of patients who do have recurrence, it's hard to know what's the best strategy. One of our fellows, Chiara Corti, just published a paper looking at our Dana-Farber experience for patients who recurred on or soon after adjuvant abemaciclib. It's small numbers. Right now, we only have 15 people, but she analyzed the tumors and actually did NGS and all these recurrent tumor biopsies and showed that for these patients who recur, 50% had lost the estrogen receptor, 90% had P53 mutations, so very bad tumor biology, and the median duration of disease control with first-line therapy was only 3 months. So this is not endocrine-sensitive disease. That's a situation where I'd also be reaching for an antibody-drug conjugate. And she's going to continue working, and we're going to learn more, particularly if you recur early versus like, what if you got abema and then you recur 5 years later? Does that same biology apply, or do you revert back to sort of a normal recurrence? So I think there's a lot more to learn there.
It's really interesting, Maya. And in those 15 patients, did they go on to the first-line CDK, essentially post-CDK?
Actually, most of them recurred so soon to the abema that it really isn't appropriate versus including some things.
I haven't personally. I can't think about patients.
Yeah, which is good.
That's recurred. Yes, which is good. Great. So I think given that we're at time, checking here, I don't think I see any questions in the chat. Your last opportunity to ask the question if you're online. But otherwise, again, would like to thank Dr. Mayer for coming and visiting us in Toronto for this excellent session. And if you are available to come join us in the evening, please do. We'll be at ours Center. Thank you.